Welcome to Deep Dive Ortho, where we cut through the noise and delve into complex medical topics, providing you with the critical insights you need for your orthopedic practice.
Glad to be here.
Today, we're tackling a true hand emergency, a condition that demands rapid recognition and decisive action. Pyogenic Flexor Tenosynovitis, or PFT.
Indeed.
It's an insidious infection that can have truly devastating consequences for hand function, if not managed precisely and swiftly. To guide us through this intricate and high-stakes area, we have a renowned expert joining us today. Welcome.
It's my absolute pleasure to contribute. You've hit the nail on the head. This is a profoundly vital area for hand surgeons and, frankly, any clinician managing acute hand conditions.
Right.
The window for effective intervention in PFT is incredibly narrow, and understanding its nuances is paramount for preserving function and preventing severe long-term morbidity.
So let's cut to the chase with the fundamentals.
Yeah.
What exactly is pyogenic flexor tenosynovitis, and what makes it such an aggressive, closed-space infection? Why this urgency compared to other hand infections?
That's where we absolutely must begin. At its core, PFT is a severe bacterial infection that erupts within the anatomically constrained space of the flexor tendon sheaths.
Okay.
What elevates it to such an aggressive and urgent status lies deeply in its unique pathophysiology and the unforgiving anatomy of the hand. These sheaths are meticulously designed for smooth, frictionless gliding of our flexor tendons.
Allowing for hand dexterity.
Exactly. They're lubricated by synovial fluid, which also provides a rather precarious vascular supply to the tendons themselves.
Precarious. How so?
Well, the problem arises because this entire system has a very limited, delicate blood supply. Once bacteria gain entry, often through a seemingly innocuous penetrating injury, perhaps a thorn or a needle stick, though sometimes some direct spread,
Right.
the body's natural immune response is severely hampered. It becomes incredibly difficult for immune cells, and critically even systemic antibiotics, to effectively penetrate and eradicate the infection within this confined, poorly vascularized environment.
So the body can't fight it off easily there.
Precisely. This anatomical vulnerability creates an ideal breeding ground for bacteria, leading to a rapid and relentless accumulation of pus.
And that causes pressure.
Exactly. As pus builds up, the pressure within that closed flexor sheath increases dramatically. We're talking about pressures that can soar to as high as 30 millimeters of mercury.
30. That's significant.
It is. To put that in perspective for your listeners, our normal capillary perfusion pressure, which keeps tissues alive, is often around 25 to 30 millimeters HDs.
So it equals or exceeds it.
Right. So when the pressure inside the sheath matches or exceeds that, you're essentially applying a tourniquet from the inside. This dangerously high pressure directly compresses the delicate vincula, the small vascular structures feeding the tendon.
Ah, vincula.
Yes. Without adequate blood supply and nutrition, the tendon rapidly becomes ischemic, then necrotic, and ultimately devitalized. This can happen astonishingly quickly, leading to scarring, rupture, or even complete loss of the affected finger. And it's not exceptionally rare either. PFT is reported to account for, somewhere between 2.5% to 9.4% of all hand infections.
That paints a very vivid and frankly alarming picture. It really underscores why early recognition is so vital. And when we talk about early recognition, the conversation inevitably turns to Knavel's cardinal signs.
Yes, Knavel.
Could you walk us through these critical indicators? How relevant are they still today?
Absolutely. These 4 signs, first meticulously described by Alan B. Knavel way back in 1912, are still definitely the clinical bedrock for diagnosing PFT. They are actively used.
Okay, what's the first one?
Firstly, we look for flexed posturing of the involved digit. The affected finger will typically be held in a slightly bent, semi-flexed position. It's a protective posture, really, to minimize pain.
Right, guarding.
Exactly. Secondly, there's tenderness to palpation over the flexor tendon sheath. This means specific, often exquisite tenderness felt along the entire length of the sheath, from the MCP joint down towards the DIP joint.
Exquisite tenderness.
Yes, though Knavel himself thought this was the most important sign, some contemporary research adds a critical nuance.
Which is?
Well, if you're waiting for that textbook tenderness, you might already be a bit late. Studies now suggest it can sometimes be a later sign, maybe indicating proximal extension of the infection.
Interesting. Okay, number 3.
Thirdly, and this is often cited as perhaps the most reliable and earliest indicator, is marked pain with passive extension of the digit.
The passive stretch test.
Precisely. Even a slight, gentle attempt to passively straighten the affected finger causes intense, sharp, disproportionate pain. It's incredibly sensitive because stretching the inflamed, pus-filled sheath directly irritates the synovial lining. It's often your first real clue.
So that's the one to really watch for early on.
I would say so, yes. And finally, the fourth sign is fusiform, or sausage-shaped swelling.
Sausage finger.
You could call it that. It refers to a symmetrical, uniform swelling of the entire affected digit, giving it that distinctive appearance due to the fluid and pus distending the space. One study actually found this to be the most common sign, present in about 97% of patients.
97%. That's high.
It is. Reflects the widespread inflammation.
That's a fascinating insight, particularly about the timing and which might appear first. So in the real world, what if not all four signs are present? Can you still suspect PFT? Does it rule it out?
That's an excellent and very practical question. Clinical reality isn't always textbook, is it?
Rarely.
Whilst detecting all four signs gives you high sensitivity, maybe up to 97%, it's crucial to understand they might be less evident or even partially absent in certain patients.
Such as?
For example, immunocompromised patients, those with diabetes, or perhaps individuals who are intravenous drug users. They may have a blunted inflammatory response.
Right. Pain perception might be altered.
Exactly. Or the inflammatory cascade just isn't as robust. The signs might be less pronounced or develop more slowly.
So what's the key then?
A high index of clinical suspicion remains paramount. As I mentioned, pain on passive extension is often the earliest and most specific finding. If you suspect PFT, don't wait for all four signs. Act on that passive pain.
Don't wait.
Don't wait. Tenderness along the sheath, whilst cardinal, might be later. So a thorough clinical examination combined with awareness of the patient's overall health and risk factors is absolutely key. You can't rule out PFT just because one or two signs are missing if your clinical suspicion is high.
Requires sharp clinical judgment then.
It certainly does. A low threshold for suspicion is vital.
You mentioned earlier how the hand's anatomy makes this infection so dangerous. Let's really unpack that. Why does the specific structure of the flexor tendon sheath create such a uniquely precarious situation?
This is fundamental to understanding why it's an emergency. The flexor tendon sheaths are precisely designed closed compartments. Their main job is providing a low-friction environment for smooth tendon gliding.
Lubricated by synovial fluid.
Correct. Each sheath has two layers. An intervisceral layer covering the tendon and an outer parietal layer forming the pulley system. Those pulleys, like A1, A2, A4, are crucial fibrous bands holding the tendon close to the bone.
Preventing bowstringing.
Precisely. Vital for grip strength. The space between layers contains synovial fluid, which provides some nutrition to the tendons, especially in poorly vascularized areas.
Okay, but the blood supply itself is the issue.
Yes, the entire system has this precarious vascular supply. Tendons get blood via small vessels, the vincula, which pierce the sheath. Once infection sets in, pus rapidly accumulates.
And the pressure rises?
Sharply. Up to 30 mmHg, as we said. This high pressure acts like that internal tourniquet. It compresses the vincula and microvasculature, leading to ischemia of the tendon itself.
Starving it of oxygen and nutrients.
Exactly. Without that, the tendon quickly becomes necrotic, scarred, compromised. It can rupture or become completely devitalized. There's nowhere for the pressure to go, and the blood supply is easily choked off. It's an unforgiving environment.
And I believe there's also this concept of a horseshoe abscess related to these anatomical connections. Sounds particularly nasty.
Precisely. The horseshoe abscess is another anatomical point that adds to the potential severity. In about 80% of individuals, there's a communication between the flexor sheaths of the thumb and the little finger.
How does that work?
Proximally, the thumb sheath connects to the radial bursa, and the little finger sheath to the ulnar bursa. What's critical is that in many people, these radial and ulnar bursae connect in a potential space in the forearm, the space of Perona.
Ah, the space of Perona.
Yes. So this interconnectedness means an infection starting in the thumb or little finger can track proximally along its bursa.
And crossover?
And potentially spread directly across the wrist to the opposite side, infecting the other bursa and its digital sheath. Imagine thumb infection tracking, crossing over, then down into the little finger.
Forming a U-shape.
That's exactly why we call it a horseshoe abscess. It's a particularly challenging, extensive presentation. Requires even more aggressive surgery due to the broad involvement, and significantly increases the risk of long-term impairment across multiple digits. Really highlights the importance of understanding these deeper connections.
That's quite a vivid image, a horseshoe abscess. Moving on, let's discuss the culprits. What bacteria are usually causing these infections, and who is most at risk for a poor outcome? Any patient profiles that immediately raise a red flag?
The most frequent offender, by far, is Staphylococcus aureus, isolated in up to, say, 75% of cases.
Staph aureus. Still number one.
Still number one. What's increasingly concerning, though, is MRSA, methicillin-resistant S. aureus. Found in up to perhaps 29% of cases, especially in certain groups like IV drug abusers, it presents a significant therapeutic challenge.
Needs specific antibiotics.
Indeed. Beyond staph, other common organisms include Staphylococcus epidermidis, beta hemolytic streptococcus, and sometimes Pseudomonas aeruginosa, particularly with water exposure or in the immunocompromised.
And mixed infections.
Yes, polymicrobial infections, 2 or more species, are vital to consider. They're more common in immunocompromised patients and are associated with a significantly higher risk of poor outcomes, including amputation. Studies show maybe a 5 times higher risk.
5 times?
Yes. And we mustn't forget specific bugs from bites. Eikenella carotens from human bites, Pasteurella multocida from animal bites. The history of injury is crucial.
Okay, so beyond the microbiology, what about the patient themselves? You mentioned specific risk factors that significantly influence prognosis. What flags tell us this patient needs even more aggressive management?
That's absolutely crucial. A pivotal study on 75 PFT patients identified 5 key factors strongly associated with poor outcomes, specifically higher amputation rates and reduced hand function. Clinicians must be acutely aware of these.
What's the first one?
First, age over 43 years. Patients older than 43 had about a 4.5 times higher risk of amputation. Suggests perhaps a diminished immune response or underlying microvascular issues.
Okay, age. What else?
Second, specific medical comorbidities, diabetes mellitus, peripheral vascular disease, or renal failure requiring dialysis. These significantly increase risk.
How significantly?
The stats are quite stark. Diabetics had a 39% amputation rate in that study. Peripheral vascular disease patients, 71%. Renal failure patients, 64%.
Wow. Why such high rates?
Likely a combination of immunosuppression, the body just can't fight the infection, and critically, poor tissue perfusion, limiting blood supply and antibiotic delivery. Their tissues are already compromised.
Right, factor 3.
Third, presence of subcutaneous purulence. If you see pus tracking outside the sheath into the subcutaneous tissue, that's a major red flag. Detected in 68% in that study.
Indicates rupture of the sheath.
Exactly. It means the infection has escaped confinement, becoming more diffuse, led to a 6.8 times higher risk of amputation.
Okay, fourth.
Fourth, digital ischemia at presentation. This is particularly grave, perhaps the most urgent sign. Its presence was linked to an alarming 25.6 times higher risk of amputation.
25 times?
Yes. It signifies severely compromised blood supply, often from the high compartment pressures. Irreversible tissue damage is imminent. If the finger looks white, cold, dusky, that's an immediate emergency.
A true surgical emergency. And the fifth factor.
Finally, polymicrobial infection, as we mentioned. Growing more than one bacterial species significantly worsens prognosis, suggests a more complex, harder-to-treat infection. Recognizing these 5 factors early guides a far more aggressive strategy.
Those factors provide a very clear framework for risk stratification. Given this spectrum, are there classification systems clinicians use to guide prognosis and treatment? I know Michon developed an early one.
Indeed, classification systems are invaluable. Michon, back in '74, created a 3-stage system based on intraoperative findings.
What were the stages?
Stage 1, inflamed sheath distended with serous non-purulent fluid, early inflammation.
Purulent fluid accumulates, distending the sheath, but the tendon itself is still viable.
The most severe stage, septic necrosis of the tendon and pulleys, widespread tissue destruction.
Prognosis obviously worsens with stage.
Logically, yes. However, a more recent and arguably more practical clinical classification system has been proposed, based on preoperative findings and observed outcomes. Very useful for immediate guidance.
How does that one work?
It has 3 tiers.
Patients present with Canavel signs, but critically no subcutaneous purulence or digital ischemia. Best prognosis, 0% amputations, about 80% return of motion. Ideal stage for intervention.
Okay, group 1 sounds good. Group 2.
Group 2. Patients show subcutaneous purulence, but no ischemic changes yet. Prognosis is poorer, about an 8% amputation rate, maybe 72% recovery of motion. The sheath has likely ruptured here.
And group 3.
Group 3, the most severe. Patients have both extensive subcutaneous purulence and clear signs of digital ischemia. Worst prognosis, a staggering 59% amputation rate, only about 49% return of motion, signifies severe tissue compromise, poor antibiotic penetration. This classification really helps gauge severity up front.
That clinical system sounds incredibly practical for frontline assessment. So, beyond signs and classification, what diagnostic tools should we use, and what are the immediate steps once PFT is suspected? What's the pathway?
Whilst canaval signs are paramount, especially that pain on passive extension, imaging and labs can complement the picture.
Like X-rays.
Radiographs, yes, primarily to rule out other things retained foreign bodies, or maybe osteomyelitis in chronic cases. Uniform swelling on X-ray isn't specific, but sometimes differential soft tissue thickness, volar versus dorsal, can be suggestive.
What about ultrasound?
Ultrasound is increasingly valuable, especially in A&E. It's non-invasive, can visualize fluid in the sheath, useful to confirm an effusion. Good negative predictive value with no fluid seen. PFT is less likely.
But limitations.
Highly operator dependent, and importantly, it can't definitively differentiate pus from blood or serous fluid. Helpful, but doesn't replace clinical judgment.
And MRI.
MRI is rarely needed for the primary diagnosis due to their urgency. We usually don't have time. It can help determine the extent if there's concern about spread beyond the sheath. But again, can't always distinguish infection from inflammation alone.
Labs. White cell count, CRP.
Laboratory tests like WCC, CRP, ESR are often elevated, but they're non-specific inflammatory markers. They tell you something's inflamed, not necessarily PFT.
So what's crucial from the lab?
Crucially, cultures obtained during surgical debridement, pus, necrotic tissue, are vital. That's how you identify the organism and guide targeted antibiotic therapy. And blood cultures, if sepsis is suspected, of course.
Okay. And immediate management steps. Time is critical, you said.
Absolutely. PFT is a surgical emergency. Time from onset to treatment is key. First aid and referral pathways are critical.
What are they?
First, elevate the hand immediately, reduces swelling. Second, splint the digit in a position of safe immobilization, or POSI.
POSI splint. Wrist extended, MCPs flex, IPs extended.
Exactly. Relaxes flexors, minimizes pain, prevents stiffness while awaiting theater. Simultaneously, start empirical intravenous antibiotics immediately, per local guidelines. Broad coverage for staph and strep initially.
Broader coverage if needed.
Yes. Extend coverage for gram-negatives and anaerobes in immunocompromised patients or based on injury history bites, IV drug use, etc.
And referral?
And critically, urgent referral. As an orange category case needing theater within 24 hours to a department with a consultant hand surgeon available. Ensures expert input without delay.
This brings us to a crucial decision point. When can non-operative management possibly be considered, and when is it unequivocally time for the operating theater? It must be a very low threshold for surgery.
You've highlighted a truly pivotal decision requiring considerable judgment. Non-operative management is, I must stress, rare and only appropriate for very specific, highly selected cases.
Which cases might qualify?
Typically, patients presenting within the first, say, 48 hours of symptoms with very mild Conneville signs, no subcutaneous purulence, no ischemia, basically matching that Group I clinical classification, catching it extremely early.
And even then, it's not simple observation.
Absolutely not. It requires hospital admission, immediate IV antibiotics, complete hand immobilization in POSI, and most importantly, extremely close observation.
How close?
Repeated, frequent clinical exams, perhaps every few hours. Serial monitoring of inflammatory markers. The clinician must personally reassess pain on passive extension, swelling, the whole picture within a tight 24-hour window.
And if no improvement?
If, after 48 hours, there is no clear, unequivocal improvement, or if symptoms worsen at all, surgical washout is immediately indicated. No hesitation. The threshold for surgery must remain incredibly low.
So most patients need surgery?
The vast majority, especially those presenting later or with risk factors, will undeniably require urgent surgical washout and debridement. It's truly a when-in-doubt, wash-it-out scenario.
That's a vital distinction. Let's get into the surgical management. What are the established techniques for decompression and irrigation, and what are the key considerations for each?
The core principle is urgent irrigation and debridement. The goal is clearing the infection and, most critically, relieving that dangerous pressure to restore tendon viability.
Time.
As early as possible, ideally within safe working hours, but certainly within 24 hours of the decision to operate. Delay significantly worsens prognosis.
Okay, the techniques.
Two primary established techniques. First, closed flexor sheath catheter irrigation, often favored for earlier, less severe cases, maybe early group 2 where extensive necrosis isn't suspected.
How's that done?
Two small volar incisions, typically over the A1 pulley proximally and near the DIPJ distally. Insert a catheter, flush high volumes of normal saline through until the outflow is clear.
Any pitfalls there?
Critical consideration. Ensure adequate outflow. You don't want to inadvertently raise tissue pressure further during irrigation. That would defeat the purpose. Some studies suggest comparable or even better motion outcomes compared to open drainage in the right cases, possibly due to less surgical trauma.
And the alternative?
Second, open flexor sheath irrigation and debridement, generally reserved for more advanced cases, delayed presentations, or where necrosis or a horseshoe abscess is evident.
What incision?
Usually a zigzag or Brunner incision along the volar digit allows thorough exposure for comprehensive debridement of pus, necrotic tissue, adhesions.
What needs protecting during open exposure?
Crucially, you must identify and protect the flexor pulleys, especially A2 to A4. Damaging these vital structures leads to postoperative flexor tendon bowstringing and severe functional loss.
And the wound afterwards?
Often left open initially, maybe with a dressing like tool grass or a drain for continuous drainage. Planned repeat washouts at 48 hours might be necessary in severe cases to ensure clearance and assess viability.
That's a clear breakdown. What about postoperative antibiotics and the irrigation fluids themselves? Any specific recommendations or evolving practices?
That's another area where practice has evolved. Traditionally, prolonged IV antibiotics were routine post-op.
And now?
However, retrospective reviews suggest that once the surgical washout is effective and infection is resolving clinically, oral antibiotics for 7 to 14 days can be effective, guided by culture sensitivities.
Allowing for earlier discharge?
Often, yes, which benefits patients and resources without compromising outcomes, provided close clinical follow-up occurs.
And the irrigation fluid? Just saline?
Regarding irrigation fluids, normal saline is generally considered sufficient. There isn't clear evidence showing superior benefit from adding antibiotics to the irrigation fluid during the washout itself.
Why not? Seems intuitive.
Studies haven't consistently shown better outcomes, and there are concerns about local tissue irritation or potentially promoting resistance.
But you mentioned emerging practices.
Yes, this brings us to an exciting area. The adjunctive use of local antibiotics and possibly corticosteroids, particularly to tackle bacterial biofilms.
Biofilms? Like in joint replacement infections?
Exactly the same concept. These are communities of bacteria encased in a protective slime layer stuck to surfaces like the tendon. They're incredibly resistant to systemic antibiotics and immune cells.
Makes them hard to eradicate.
Extremely. They're a key reason infections persist or recur. Targeting that biofilm directly is a frontier, aiming to break down that shield. It mirrors strategies in periprosthetic joint infection management using local drug delivery.
So potentially local antibiotics or steroids in the sheath post-washout.
It's an area of active research, yes. Potential to reduce stiffness and recurrence. Still evolving for PFT, but a promising avenue.
Even with prompt treatment, PFT can lead to significant complications. What are the common challenges clinicians and patients face long-term?
Despite best efforts, PFT can result in substantial morbidity. The most prevalent challenges include
Stiffness, I imagine.
Firstly, yes, stiffness and restricted range of motion, exceedingly common. Maybe 10–25% don't regain full active movement. Results from dense tendon adhesions. The tendon gets stuck thick in joint capsules, surgical scarring.
Can that be treated later?
Sometimes a secondary procedure, flexor tenolysis, is needed to surgically release adhesions once everything is settled, usually months later.
What else?
Secondly, flexor tendon scarring and rupture. The high pressure and compromised blood flow damage the tendon. It becomes scarred, unhealthy, prone to spontaneous rupture, even months or years later. Often needs complex reconstruction like grafting.
And the worst-case scenarios.
Thirdly, soft tissue necrosis and digital ischemia. Severe cases, delayed presentation can lead to irreversible tissue death. Blistering, necrosis, even frank gangrene.
Necessitating amputation sometimes.
Unfortunately, yes. Partial or complete amputation can be unavoidable with profound functional and psychological impact.
Other complications.
The horseshoe abscess, as discussed, remains a major challenge if it occurs. And persistent pain is also common, related to scarring, stiffness, or nerve irritation.
Given that high risk of debilitating complications, what does this mean for the role of rehabilitation? It must be crucial.
Rehabilitation is absolutely unequivocally critical. Without it, even perfect surgery might yield a poor functional result. Early access to a specialist hand therapist is essential.
How early?
Ideally involving early active motion, sometimes starting the day after surgery if the wound is stable and the surgeon agrees. This early motion is paramount to prevent adhesions and promote tendon gliding.
And how long does therapy last?
Patients typically require supervised therapy weekly for at least 6 weeks, often much longer, to guide them meticulously through recovery.
Are there specific phases to the rehab?
Yes, it's guided by tendon healing phases, similar to flexor tendon repair rehab, conceptually. The protective phase, 0–4 weeks post-op. Focus is protecting the healing structures. Motion must respect suture limits. Gentle passive ROM may be place and hold exercises.
Place and hold.
Therapist passively flexes the finger. Patient holds it actively without full active flexion against resistance. Gets tendon gliding without stress.
Okay.
Then the transitional phase, 4–6 weeks. Repair strength increases. Exercises gradually advance gentle active flexion within controlled ranges. Therapist assesses scar and excursion.
And finally.
The full mobilization phase, 6+ weeks. Gradually increase activity, introduce strengthening, work towards full functional recovery.
Were there standard protocols?
Various protocols exist, Nantong, St. John, Manchester, often combining passive and active motion in a protective orthosis. But the critical point is they are guidelines, not rigid timetables.
So individualized therapy is key.
Absolutely. Clinical judgment is paramount. Therapy advances based on the individual's tissue response and observed tendon excursion, like using the pyramid of progressive force application concept.
Gradually increasing force as tolerated.
Exactly. Plus, careful orthosis used to prevent complications like PIP joint flexion contractures. Early sustained hand therapy makes the difference between a stiff finger and a functional one.
This definitely sounds like a condition requiring a collaborative, integrated approach, not just a surgeon's problem.
You're absolutely right. It is unequivocally an interprofessional team effort. Managing PFT effectively demands seamless coordination across the entire healthcare team.
From the very beginning.
From initial presentation, emergency department staff, nurses play vital roles in assessment, antibiotics, perioperative care, monitoring. Early, clear communication with the hand surgeon is essential for planning.
And postoperatively.
It's a true team effort. Doctors for medical management, nurses for monitoring and care, and crucially, hand therapists guiding recovery. Social workers, too, sometimes for comprehensive support, addressing social or occupational reintegration needs. No single discipline can manage this alone.
And finally, what's crucial for patient education and shared decision-making in such a serious condition, how do we empower patients?
That's arguably one of the most vital aspects. You, as the clinician, must counsel patients with absolute clarity using accessible language. Explain it's an emergency requiring urgent treatment to save finger viability and function.
Be frank about risks.
Yes. Engage in frank, honest discussions about potential complications. Restricted motion, pain, stiffness, even amputation. It's about empowering through truly informed consent.
Considering their individual needs.
Exactly. Discuss their values, occupation, hand function requirements. A pianist's needs differ from a laborer's. Understanding what their hand means to them allows tailoring expectations and rehab goals, makes them an active participant, fosters trust and adherence to the demanding rehab.
That was an incredibly comprehensive and insightful deep dive into pyogenic flexor tenosynovitis. Your breakdown of the signs, risk factors, classifications, and a nuanced approach to treatment and rehab has been invaluable.
It's a condition where early recognition and a methodical, evidence-based approach plus strong teamwork can truly make the difference between lifelong disability and a meaningful return to function. I hope this helps equip clinicians to tackle it effectively.
A crucial message indeed. For you, our listeners, we hope this exploration provides a clearer, actionable understanding of PFT's complexities and the need for urgent action. Consider the next time you encounter that hand infection pattern. How will you apply these principles to safeguard your patient's function? If you found this discussion valuable, please take a moment to rate and share Deep Dive Ortho. Join us next time as we continue to unpack the most important topics in orthopedics.